Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar, Advances in Heart Valve Replacements. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com almost 15 years ago in 2006. The mission of our website is very, very simple. We want to educate and empower patients with heart valve disease. And this webinar, which has had registrations from over 500 patients across the world, was designed to support that mission. Now, during the webinar, you're going to be in what's known as listen-only mode, but I'd encourage you to submit your questions in the control panel that's on the top right part of your screen. We will do our best to answer those questions during the Q&A session of the webinar. Lastly, as we conclude the webinar, I'm going to ask you to complete a very, very quick 5-question survey. So let's look at the agenda for today. And I'm going to go ahead and I'm going to introduce the featured speakers. We're going to talk all about heart valve disease, and then we're going to dive deep into heart valve replacements. We're going to conclude, as I previously mentioned, with a Q&A session, and then have a quick survey. Now, for the featured speakers of this event, I am humbled that they're taking time away from their very, very busy practices at the Mayo Clinic to help educate our community. I'd like to start by welcoming Dr. Arman Arghami to the webinar. He is a cardiac surgeon at Mayo Clinic in Minnesota, and his specialties include heart valve repair, heart valve replacement, atrial fibrillation, coronary artery disease. And Dr. Arghami has a very unique focus in minimally invasive and robot-assisted techniques that we're going to hear about today. In addition, another great member of the heart team is Dr. Mackram Eleid, who is an interventional cardiologist at Mayo Clinic in Minnesota. His specialties include heart disease, heart valve disease, coronary artery disease. And Dr. Eleid has a focus in his practice specific to transcatheter, aortic, and mitral valve replacement. Now, some of the people on the phone know this, but some may not. That means that Dr. Eleid can replace valves using catheters without an incision to the patient's chest or ribs, and we'll talk about that today. Needless to say, I could go on about the achievements of both Dr. Arghami and Dr. Eleid in cardiac care. I could ramble on and on. What I'll do, though, is I'll show you what I love personally is the smiling faces of their patients. Whether it's Rosemary and Tom Rice, Cheryl Mann, Scott Kinghorn, Herman Cantor, Wes Edens, Gary Stanko. These are all folks from the HeartValveSurgery.com community who have had very successful surgical or interventional outcomes at Mayo Clinic. And to give you an idea of the scale and the scope of Mayo Clinic, whether it's at Mayo Clinic, Minnesota, Mayo Clinic, Arizona, Mayo Clinic, Florida, in 2020, this incredible organization performed over 2,000 heart valve procedures. So we are in great hands today with Dr. Arghami and Dr. Eleid. And now with that, I'd like to introduce you all to Dr. Arman Arghami.
Thanks, Adam, for such a great introduction. I'm pleased to be here and be part of this program and this educational session. I would like to start with explaining the heart a little bit. I know some of your viewers know this very well, but I thought we'd bring everybody on the same page. Heart has 4 valves that are one-way valves that are biological masterpieces that are designed to work for 80, 90, 100 years. If you do the math, that means over 3 billion cycles of opening and closing, which are mind-boggling. We separate them into 2 sides. The left side of the heart that pumps the blood through the rest of the body to nourish and oxygenate it. And it has 2 valves, mitral valve and the aortic valve, which will be the focus of today. The right side of the heart, which receives the deoxygenated blood and sends it to the lung to get oxygen, has 2 valves as well, tricuspid and pulmonary valve. We're going to be focusing on the mitral valve for now. Can you click next, please? So mitral valve disease, they're divided in two broad categories. One is primary, one is secondary. The primary, what do we mean by that? Mean that the valve itself is the problem. The mitral valve has two leaflets or two sides that close in the middle, like a parachute. I put a little picture up there for you guys to remember. Like a parachute has cords that holds it down. This valve can be diseased. It can be stretchy and prolapse. We call it mitral valve prolapse. When it prolapses too much, the gap appears between it and it can leak. Sometimes those cords that, like parachute cords, can break or tear, and we call it a flail segment. A part of the valve won't be supported anymore. And this can cause valve to leak and not hold the blood in one direction. We call that regurgitation. Sometimes the valve can get diseased and tight. We call it stenotic valve. It doesn't allow the blood to easily flow through one direction. But secondary mitral valve problems are similar problems, but the main issue is not the valve itself. It's usually something else wrong with the heart that is causing the valve to leak. And I have a picture of that next. But what is the symptoms? How do patients know that they have a problem with their valve? Fortunately or unfortunately, most of the mitral valve regurgitation patients don't have any symptoms to begin with, at least the beginning, because heart is very redundant and can tolerate a lot of issues. It won't show any problems until later. Now, when the symptoms start is when the heart starts getting bigger and bigger, and it won't be able to squeeze blood normally anymore. And that's when you get short of breath when you do activities, when you climb a stairs or walk far distance. Patient can get irregular heart rhythm that we call atrial fibrillation. That's from the stretching of the chambers of the heart that starts firing abnormally. They can have difficulty laying flat because they feel they're suffocating. We call that orthopnea, and many other symptoms. On the next slide, this is a picture of, on the left, you have a primary mitral valve disease, which you can see on the picture, there's a cord that is broken. So something wrong with the valve itself. On the right picture, the heart is enlarged. You can see the bottom chamber is quite enlarged, sometimes from a heart attack or something like that. And it's pulling on those strings and holding the valve down and not allowing it to close properly. Now, what can we do? If you go to the next slide, there are two things we can do, a repair or a replacement. The replacement is simple. You cut the old valve out and sew a prosthesis in there. There are different types that my best friend, Dr. Eleid, is going to tell you a few of them down the road. But what I'm going to focus on is repairing your own valve. And that's the better option. So I'm not going to cut it out. We're going to explain how we're going to do that. Can all valves be repaired? Not all of them, but a good majority, especially those with the primary mitral valve problems, can be repaired. And I'll show you that. For example, last year at Mayo Clinic, out of all the mitral valve procedures, more than 2/3 were repaired. And what are the options for replacement, which again, Dr. Eleid will go over with us. I'm going to start with an example. Can you click next? This is an echocardiogram of a 64-year-old female who came to us. As you can see on the left picture, there's a piece of cord that's broken, and almost you see it swimming in the upper chamber. The right picture shows the direction of the blood by the color, and that blue part that it goes into the upper chamber is abnormal, is the leakage. If you click next, you can see the 3D reconstruction of this valve by the echocardiogram, and it's much more visible, and you can see that broken cord. We'll get to this patient a little later on. Now, if you click next, one of the most common questions I get is, as I said, most patients don't have any symptoms. So they're like, why should I have a surgery if I don't have any symptoms? I have a few answers for those patients. One is these don't improve. The broken cord is not going to attach itself back on, and no medication can fix the leaky mitral valve. And actually, they're actually progressive. They get worse over time. The more tension, the more pressure you put on these stretchy valves, more things can break and leak. If you click next, the other more important thing is that even in asymptomatic patients, patients who don't have any symptoms, we've shown that they don't live as long as they're expected to. So that's a very important thing. If you click next, and more important than that, we've shown that if you repair the mitral valve, you can bring back their life expectancy back to where they're supposed to be, like as they never had the disease. That doesn't happen if you replace the valve. It only happens if you repair the valve. Using this data for many years now, if you click next, American Heart Association has been recommending early surgery for mitral valve, even in asymptomatic patients. Click next, please. So no symptoms. If a center can offer more than 98% chance of repair, that means that they can offer surgery even in asymptomatic patient. Another common question that I get is that how do you actually repair a valve? And I would like to share a piece of history on that one. If you click next, Adam, please. This is a picture of Dr. Dwight Magoon, one of the pioneers of cardiac surgery at Mayo Clinic. And this is his first description of a repair of a mitral valve with a broken cord in 1968. That's the dawn of cardiac surgery, if you guys know and remember. Using this awesome description and this technique over the past few decades, we have perfected this technique. And if you click next, and we have been able to create this simplified and really effective technique we call a triangular resection, where we cut a piece of valve in a triangle or a pie shape where the broken cords are, and we repair it, and then we reinforce the valve with a band around it. We call it annuloplasty. If you click next, using this technique, we have been able to repair over 8,000 mitral valves in the past few decades with very good success and very low risk. If you click next item, the risk of mortality in our patients is 0.7%. And if you only look at those patients who have very minimal symptoms, that risk is less than 1 in 1,000 patients. If you click next, the second most common question I get is that if you repair the valve, Dr. Arghami, what's the chances of this working still and not break down again? Which is a very important question. The durability is great. If we look at this chart, it's a little complicated chart, but if I break it down, as I said, there are 2 leaflets on the mitral valve. If you only repair the posterior one, which is the most common leaflet to be the problem, the chances of the patient needing another surgery in 10 years is only 5%. It's even better than a mechanical valve. If you repair the anterior leaflet, the risks are still pretty good in the 10 to 15% chance, so 85% chance that valve is still working in 10 years. And if you do both, it's somewhere between about 10%. If you click next. Now, we gathered many decades of experience and we brought it to the 21st century, applied the new technology, i.e. the robotic technology to it. Click next, please. Now we can offer the same proven and durable repair through 3 different approaches. The median sternotomy, which is dividing the breastbone, through the incision between the ribs, we call it mini sternotomy, or with a few tiny little pokes in the right chest with a robotic assistance. Click next. I'm going to show you a few pictures of the robotic technique. This is a robotic operating room. They say there's 10,000 steps to a robotics or any cardiac surgery, that every step is important. As you see, the patient is on the right side of the picture. There's a cardiopulmonary bypass in the middle of the picture in the back. And one of the unique things about Mayo Clinic is that we use 2 surgeons. Click next. One sits at the console, one at the bedside to help with the robotic arms. This allows 2 sets of trained eyes to look at the mitral valve and come up with a great plan of a repair, which is going to be durable and great. Now, next one. The robotic repair doesn't mean that the robot does the surgery. As you can see here, the surgeon moves these joysticks basically, and the robot arms move accordingly. And that's where the surgery starts. Click next. This is a short clip of that patient that I showed at the beginning that we're going to repair. We make a small incision on the side of the heart, get into the left atrium. As you see, that's the cord that was broken that you saw in the picture. I'm going to cut this piece out in a triangular fashion, like a piece of pie. And this is magnified, by the way. This is significantly magnified. The mitral valve is almost like a $half size. This is sewing the leaflet back together. We use permanent sutures. We tie it down. You can almost see that the valve doesn't look like it was cut. And this is that band I told you about. We're putting it around to reinforce the mitral valve to allow these leaflets to come closer and meet further in the middle and be more efficient. We tie those down with special nut clipper, and we test it before we close it. We're putting some water or saline behind the valve, and we're testing it. In this specific case, there was a little leakage left, and that's why the mitral valve is not a science, it's an art. Here, we decided to put an extra stitch in that area we call a cleft, where naturally there's a division between the two sides of the same leaflet, and sometimes it leaks. So it's more of an art. We have to see what's wrong, and every patient requires a different repair. It's unlike a replacement. We tested again, and this time it looked great and perfect. If you click next, we close things up and we check with the echo on the table while the patient's still asleep and make sure that all that blue that was going back is not there anymore. So click next, please. What's the benefit of the robot? It's much smaller incisions. The patients stay in the hospital and in the ICU half the time. There's less bleeding, so less blood transfusion. Patient use less narcotic pain medicine, and we all know about the opioid crisis we have. And when they go home, they have a faster return to work, almost half the time. Next. We have been able to do more than 900 robotic cases since 2008 that we started it. We have been able to successfully repair all those valves. We had to convert to sternotomy for a valve repair reason. Major complications are less than 0.1%, and reoperation is less than 1%. Next one. So when I summarize my part, I want to mention this. Mitral valve, in degenerative mitral valve disease or the primary mitral valve disease, when there's severe regurgitation, consideration for early repair should be given. Repair is always better than a replacement. And mitral valve repair can bring the survival back to normal among those patients almost as they didn't have the disease. And robotic surgery is an alternative to open surgery and can be applied to all sorts of valve problems. Now, what if the patient can't have surgery? If they have very a difficult situation that they cannot undergo surgery? That's where I'm going to hand the talk to my best friend, Dr. Eleid.
Well, thanks, Arman. That was a great description of mitral repair, and it's really amazing to see what you guys do in the OR. Arman and I work together hand in hand in seeing patients with valvular disease, and I'd like to thank Adam again for the opportunity to present here and all of the attendees here, that many of whom are patients. The question of if a patient cannot tolerate surgery, and that's a common scenario. We have patients with mitral regurgitation who are higher risk for surgery due to comorbidities, such as a prior heart surgery, for instance, or lung disease or some other organ disease. In those patients, we have transcatheter options, which has been a huge evolution in the last 10 years. The edge-to-edge repair technique mimics a surgical technique called the Alfieri stitch, where the posterior leaflet is clipped to the anterior leaflet in the middle. You can see on the figure down below that it creates a double opening mitral valve with the edge-to-edge repair technique. And this is currently commercially available through the MitraClip system. And there's also another device that's under investigation called Pascal that can achieve this as well. So this is particularly useful for patients who have a degenerative mitral valve with a ruptured cord and have a central location of leakage. But there's also a lot of other exciting therapies under development, transcatheter replacement valves that can be delivered through the femoral vein in the leg through a minimally invasive approach. And several of these are in the stage now where they're in the early feasibility stage that is being studied closely to look at the safety and efficacy. And then others are also in a larger trial phase And patients that have primary mitral regurgitation may be candidates for these. Next slide. We did briefly discuss the differences between a primary mitral regurgitation and secondary, but I just wanted to reiterate that secondary mitral regurgitation is more of a disease of the ventricle rather than the leaflets themselves. And this is also a common problem that we're seeing. And patients with secondary mitral regurgitation are often not good candidates for surgery, so transcatheter therapies are needed. Next slide, please. So the MitraClip was studied in patients with secondary mitral regurgitation, and one of the largest trials was the COAP trial, and that was done here in the United States. And you can see curves on the bottom of the screen that show both survival and rehospitalization that were less with edge-to-edge repair in these patients. But one of the keys is that all of these patients that in the trial were optimized on heart failure medications and had really rigorous medical treatment first to make sure that they needed a mitral valve repair. We also have a lot of other options for patients with this problem too that are being investigated. I mentioned the Pascal device, which is similar to MitraClip, and that's being tested in a randomized trial, which achieves a similar edge-to-edge repair. And then there's also the Tendyne valve, which is a self-expanding valve that's delivered through a minimally invasive transapical approach. So that's another hybrid procedure that our surgical colleagues will get access in the ventricle at the apex and then advance a valve through there. And then we also have other types of valves, one of which is called the Sapien M3 valve, which you see a picture on the bottom right of that valve. And that's also being studied for these types of patients who have secondary mitral regurgitation. So lots of exciting innovations in this area, and we are evaluating patients for these trials when they come to Mayo Clinic. Next slide. So I'd like to transition to aortic stenosis. This is another common problem that we face, and over 10% of people over 80 will develop aortic stenosis that may require intervention. So it's a common disease of aging, but it's also common in younger patients in whom have a bicuspid aortic valve. And up to 2% of the population may have a bicuspid aortic valve, meaning that two of the leaflets are fused together instead of having three leaflets. Next slide. This diagram shows a normal aortic valve over on the left. You can see the large opening of a normal aortic valve. But when it becomes stenotic, the valve no longer opens normally. And this puts the heart under a lot of pressure. And the ventricle has to generate a high pressure in order to get the blood out of that small valve. And the only effective treatment for aortic stenosis is an aortic valve replacement. And let's go to the next slide. So we approach patients with aortic stenosis in a team approach. So Dr. Arghami and I see patients together, and oftentimes with our cardiologist colleague as well. And we will try to determine what the best option is for the patient using a team approach. This is really critical to make sure that patients know all of the options and have the best information to make the best decision. Next slide. We have different replacement valve options. So this is a really critical decision. And when a patient is faced with having to have a valve replaced, one of the first questions is, what type of valve should it be? And you can see on the left, a mechanical aortic valve is typically going to be a bileaflet prosthesis that has two discs that open and close. And these have the best durability of 30 years or more. But they also require warfarin anticoagulation. And this is one of the important considerations. Tissue valves are usually either made out of cow pericardial tissue or pig valves. and they typically have a durability of 10 to 15 years, sometimes more, and occasionally even less than that. But on average, 10 to 15 years, and don't necessarily require anticoagulation. The transcatheter aortic valves that we're implanting nowadays are perceived to be similar to the surgical tissue valves, but long-term data is still not available. So there are still some uncertainty about the durability of the transcatheter aortic valves, and this is being closely looked at as patients are followed in the long term that have been enrolled in the trials that led to the approval of the transcatheter aortic valves. Next slide. So one of the biggest questions to ask patients regarding mechanical versus a tissue valve is the ability and willingness to take anticoagulation. So we have a shared decision-making discussion with all of our patients about which type of valve they want. And we take into account many factors. The updated American College of Cardiology guidelines that have an algorithm based on age, which is one of the factors that we take into account. In terms of aortic valves, we know that patients who are in their 50s generally benefit the most from a mechanical valve, typically 50s or younger, in terms of long-term survival. And there's several trials that show a survival benefit of mechanical valves compared to biologic or tissue valves in patients who are in their 50s or younger. On the other hand, it's reasonable to choose a bioprosthesis in most patients who are 65 or older. But a lot of different details need to be taken into account. A patient's bleeding risk, their longevity, how long do we expect you to live? And that's oftentimes a very difficult thing to predict for anyone. But also lifestyle, and what would be the risk of a second operation as well. And now that we have valve-in-valve as an option, that also comes into play. And how suitable would that valve be to accommodate a transcatheter valve 10 to 15 years in the future? So those are all important questions that we ask for each patient. Next slide. We also take into account the risk profile of our patients in terms of what is the risk of open heart surgery, which is based on a risk score that takes into account over 20 different variables. We also take into account patients' frailty, which is generally their strength and physiologic reserve, their ability to tolerate stress. And then we look at other comorbidities, such as kidney disease, and whether or not anything else needs to be done. For instance, does a patient also need bypass grafting surgery because of severe coronary disease, or can it be treated with stents? Those are all very important questions that we have to assess in determining the best treatment. Next slide. And if we had made a decision about a tissue valve for our patients rather than a mechanical valve, then we also take into account their age and surgical risk in determining surgery versus TAVR. The ACC guidelines recommend surgery as the class 1 indication for patients who are younger than 65 and have a life expectancy of more than 20 years. And part of that is because of the track record of surgical aortic valve replacement and a little bit more long-term follow-up of surgical aortic valve replacement that we have available. TAVR, or TAVI as it's shown here, transcatheter aortic valve implantation, is reasonable for most other groups of patients with aortic stenosis. So if they're 65 or older, it's considered a class 1 indication or surgery. So there's a lot of options for most of our patients, and we take into account a lot of factors. Next slide. This is just a slide from one of the most important trials of transcatheter aortic valve replacement that was published 2 years ago, and this was the PARTNER 3 trial. This led to approval of the balloon expandable sapien valve in patients who were considered low risk for surgery that had isolated severe aortic stenosis. And one of the findings of this trial was a reduction in a combined endpoint at 1 year in patients who had transcatheter valve replacement instead of surgery. And this was a combined endpoint of mortality, stroke, and rehospitalization. And this just shows some of the percentage risks for patients at different time points. We see atrial fibrillation on the top was less common with transcatheter valve replacement than surgery, and death or stroke was also less common with the transcatheter valve replacement compared to surgery. Length of stay, of course, was less, as we would expect. So this is one of the reasons that Dr. Arghami and I are performing transcatheter valve replacement on more and more patients. And this has really been a revolution in cardiology, one of the biggest breakthroughs in the field of heart surgery and cardiology in the last decade. Next slide. One point here that I would just add on that slide is that pacemaker risk is still a little bit higher with transcatheter valve replacement. So for patients to be aware of, even though it wasn't statistically different in this low-risk trial, we do see that it's higher in most patient groups. And the left bundle branch block is a conduction change that can occur with TAVR, and that is higher and more common with transcatheter valve replacement than surgery. Next slide. So transcatheter valve replacement is done with moderate sedation nowadays. So our patients are awake but sedated and comfortable, breathing on their own, and the procedure usually takes 1 to 2 hours. So it can be completed very rapidly, and usual length of stay is about 1 day for most patients in the hospital. We do an echocardiogram as well immediately at the end of the procedure to make sure that everything looks good. And then some patients have to be monitored with a rhythm monitor after discharge, but most patients don't require any rhythm monitoring after discharge from the hospital. Next slide. This is just an example of a different scenario of a patient with a bicuspid aortic valve who is 70 years old and opted to proceed with transcatheter valve replacement after we looked at the anatomy in detail. And you can see some of the computed tomography images up on top there. You can see that there's fusion of 2 of the leaflets of the valve, the left and right cusp, and some calcification in that area of fusion. And we felt that the anatomy was favorable for transcatheter valve replacement, and there were no other indications for surgery. And that's a very important point because many of our bicuspid patients will benefit more from surgery, particularly our younger patients and those who have an ascending aortic aneurysm. But in this case, our patient had a great result with transcatheter valve replacement. You can see this video of valve deployment. Hopefully, there we go. You can see the contrast being injected into the aortic root, and we use that as a guide to deploy the valve. And this is the balloon expandable valve being deployed. And after 10 seconds, the patient has a brand new aortic valve. So it's really amazing. Next slide. Bicuspid aortic valves haven't been formally approved for TAVR, and actually they've been excluded from a lot of the clinical trials, so it's still an area of question. And we still don't have a randomized trial for patients who have bicuspid aortic stenosis. But we do have a lot of observational data, and this is data from the Transcatheter Valve Therapies Registry that showed comparable outcomes in patients who have a bicuspid valve with aortic stenosis compared to tricuspid undergoing transcatheter valve replacement. There was a signal for slightly higher risk of stroke, 2.4% versus 1.6%. So that's something that we think needs further evaluation, and also a slightly higher rate of pacemaker as well, 9% versus 7.5%. So many are supporting that a randomized trial be done in patients with bicuspid aortic valve and that's something that we're still waiting for. Next slide. So it's really a changing paradigm in deciding about transcatheter valve replacement and surgical aortic valve replacement. And many patients who have isolated severe aortic stenosis will be good candidates for transcatheter valve replacement. But there's a lot of other scenarios where surgery is still the best option. And that includes patients who have multiple valve lesions who are good candidates for surgery, bicuspid aortic valve with aortic aneurysm, those patients who would benefit the most from a mechanical valve. And another example is patients who have diabetes and severe coronary disease that would benefit more from bypass surgery as well at the time of their valve replacement. But those are just a few examples, and a lot of these factors need to be taken into account. Next slide. Yeah, so I think that was the end of our presentation, but now we're looking forward to discussing many of the questions, and I'll hand it over to Adam.
Yeah, Dr. Eleid and Dr. Arghami, on behalf of the patients, thanks so much for putting together that presentation to make us very familiar with your paths and approaches to managing and treating valvular disorders. We've gotten a whole bunch of questions that have come in from the patients out there, and we're just going to go ahead and dive right in. I don't know that one is designed for you, Dr. Eleid, or one is designed for you, Dr. Arghami. So if you guys can just answer them as you see fit, I'm sure our patients would appreciate it. And let's talk about something to start with that our community is very fascinated with, which is medical technology and some of the new therapies and new materials that are coming out. This question comes in from Brent about polymer valves, and he says, what is the latest update on polymer valves? Is it possible these valves can last a lifetime without any drugs? And are there any other new types of heart valve materials we should know about?
I can take that one. Very good question, Brent. The field is always growing and investigating, and we have come a long ways from the initial valve types. I don't know if any of you have seen the ball and cage valve, which was historically an important valve, but not being used anymore. Polymer valves are also very fascinating with good promises. They're still in development. There have been one or two human tests that I'm aware of, but like anything else, we just have to wait for the technology to mature. And as soon as they're available, whether they can be implemented surgically, or the polymer has the promise of being flexible and hopefully be able to be implemented through TAVR technology and not require surgery, and then have the valve for a very long time. In terms of other valve types, again, there's a lot of areas of investigation, improving tissue valves and whatnot. One of the things that Mayo Clinic researchers are working on is trying to create a valve that is impregnated with patient's own cells. So there's no rejection or there's no reaction, if you may say, and has the promise of being as your own valve, literally. But again, a lot of this are in the future, and the future looks bright.
Yeah, and Dr. Arghami, with a kind of lead in to that answer, I think that patients are all probably wondering what I'm wondering is, how far in the future do you think it might be before Mayo Clinic, for example, is growing patients' own valves? Can you even guesstimate on that?
It's hard. As you and your listeners know, medical devices are not like iPhone that you can print out a new version every year. They have to go through rigorous work to make sure they're safe, they're durable, they don't have any long-term reactions. So it will be soon, but I can't promise any time.
Okay. All right. Moving on to the next question is about the COVID-19 vaccine. And we get a lot of questions about this, given this very difficult and trying time in healthcare. Amy asks a really great question. My son has moderate aortic valve disease due to stenosis and regurgitation. We believe he will need a replacement. I'm concerned about him getting the COVID-19 vaccine, given the reports we've seen about myocarditis. Do you have any advice for a mom?
Yeah, I think I can definitely feel for Amy and wanting to do the best thing for her son. And I'm not sure how old her son is, but I assume he must be relatively young. You know, there are some reports of slightly higher risk of myocarditis in younger males. But when you weigh that small risk with the risk of COVID-19 infection, particularly in someone whose immune system might be weakened by cardiac surgery, I think that would really favor vaccination. So in most cases, I think most likely he would benefit from vaccination.
And a quick follow-up to that would be, for any patient on the line who might be getting ready to have a valve procedure or may have just had a valve procedure, is there any reason that you know of in which someone should not get vaccinated?
I don't know, Mac, you can say, but for our surgical patients, our current advice is to distance it about 2 weeks, so we don't mix symptoms or any other overlapping issues between the surgery and the vaccination.
Right. Yeah, I think I would agree with that. I think there's some very infrequent scenarios where some patients should, like patients who've had a stem cell transplant, should check with their transplant doctors, but the vast majority of people will benefit.
Great, thank you. Moving on to another form of valve replacement. We haven't talked about it yet, so I'm thrilled that Stacy asked this question. It's all about the Ross procedure, and she says, I'm in my late 40s. I'm very outdoorsy. She does hiking and kayaking. I need a new aortic valve due to calcification and stenosis. I've been reading about the Ross procedure. I understand it's a 2-valve replacement. Is the Ross less durable because of that? What are the doctor's thoughts on the Ross procedure?
Very good question, Stacy. I'll take this, Mac, if you're okay. Ross procedure, just going to briefly explain it to those listeners who don't know about it, is removing your own, so it's for treatment of the aortic valve, but you remove the pulmonary valve. If you remember from the first slide that I showed, that's the right-sided valve, and you cut that out from the own patient's heart, put it in the place of the aortic valve, and then put another prosthesis for the pulmonary valve. The reason being, the pulmonary valve is in a less pressured system, so the blood pressure on the right side of the heart is not as strong as the left side of the heart, so it should last longer, and it's, I don't want to say less important valve, but it has less effects. But you give the patient their own valve on the left side, which is important. Now, the benefit, the other benefit is that because both valves are tissue, one your own tissue, the other one is animal tissue, you don't have to be on blood thinners. Now, this is a little bit of a controversy, and there are some proponents and opponents of this technique, because you turn one valve problem into potentially 2-valve problem. Now you've changed 2 valves. But it does have its own merits, especially in the younger population, especially those that cannot tolerate or should not be put on blood thinners on a mechanical valve. One of the good examples is young females that are planning to have kids and get pregnant, and that's not conducive for somebody on warfarin. And there are a few other examples. So Ross procedure is good in the younger population, and it requires a good discussion between the patient, the surgeon, and the cardiologist to come up with a good reasoning plan. A very good question.
Yeah, and Dr. Arghami, I love the way you contextualize the appropriateness of the Ross procedure by age and gender, as it is a very unique procedure. And to Stacy out there, so you know, I had a Ross procedure performed over 15 years ago. And so far, I've been free from any form of reoperation. If you have any questions, you can simply email me at adam@HeartValveSurgery.com, and I will do my best to support and answer you and any questions you have about the Ross procedure. All right, so moving on, Dr. Eleid, I'm hoping that this is right in your strong suit or sweet pocket. Eli is asking about valve and valve, and one thing we've been talking about at HeartValveSurgery.com is the lifetime management of valve disease, which sometimes gets overlooked. And Eli is a testament to that. He says, I am 93 with an Edwards TAVR size 23 millimeter implanted in 2017, and I've got a current left ventricular ejection fraction of 65 to 70%. Go Eli. Should this valve fail, what is the current likelihood of a successful valve-in-valve transcatheter insertion of another tissue aortic valve of adequate size to function for at least several more years? Thoughts on this, Dr. Eleid?
Yeah, well, I really like the way Eli thinks, and I think he must be a go-getter. This is great to see. But usually what we have to do, I think in many patients we do have some evidence now that TAVR in a TAVR is feasible, and the safety of it is comparable to the first TAVR in many patients. But I think the one group of patients where we have to be even more careful is those patients who have a smaller aortic root, and that's true also for surgery too. With TAVR, the open cells, you can see this image of this sapien valve, that it's open cells, so that allows for blood to flow freely. But the sinuses of Valsalva above the valve need to be large enough to accommodate a valve-in-valve, because when that new valve goes in, it will push the leaflets off to the side, and we need to make sure those leaflets don't prevent flow through the coronary arteries, which are right in that area. So a CT is used for planning of that, and most patients will be candidates for that, but it depends on their anatomy.
Great, thanks so much, Dr. Eleid. I hope that helped you, Eli. I know it helped me. And we're going to move on to a question that comes from Amy about a valve we haven't talked about much today, which is the tricuspid valve. And she asks, it seems that I have a very leaky tricuspid valve. Could the tricuspid be replaced using minimally invasive techniques?
Sure, I'll take that one. Thanks, Amy, for asking the question. Tricuspid valve is the opposite valve of the mitral valve on the right side, and they actually go hand in hand. A lot of times when you have a leaky mitral valve, you can get a leaky tricuspid valve. And even more recently, we tend to repair those tricuspid valves at the same time that we fix the mitral valve. I don't know if she also has a mitral valve problem or if that has been treated before. But it can be treated, and we can do that robotically as well. And as I mentioned, we do it very frequently together. So it's a very doable procedure, and almost always can be repaired. So replacement can also be performed, but less likely is required. And there are also catheter-based options, which, again, Dr. Eleid can allude to it,
Sure.
which is also possible.
No, that's exactly right. Yeah, in the patients who are not good candidates for surgery, who have severe tricuspid regurgitation, we do have several transcatheter options that we're investigating. There aren't any approved options, but we have clinical trials, and some of these are very viable options. One is a edge-to-edge repair option, similar to what we showed you on the mitral valve. And then we also have a replacement valve option too, that is it's a randomized trial. So so it's very exciting.
Great, and let's now talk about a specific type of valve, the pig valve. And this is a question that comes in from Veronica. And I know, Dr. Arghami, you mentioned earlier about the advantages of always doing your best to have the patient have a mitral valve repair procedure done, but at times I'm imagining, and if you could talk about this, it would be helpful, that that's just not possible, and you need to replace the valve. And Veronica asked, I've seen some interviews on Adam's website that suggest a pig valve is better in the mitral position. Why is that?
Well, as you said, Adam, I think sometimes it does require a replacement. A lot of times are not the primary mitral valve disease, or sometimes a secondary mitral valve disease that requires that. So it's not a problem with leaflets. Now, in terms of the valve types or brands, I would like to caution your viewers again to be cautious and a lot of times maybe trust the data and trust the surgeons in this regard, because as you can imagine, a device or a valve that takes 10 or 15 or 20 years to really show the durability and the consequence of it, it's really hard to study. Somebody has to follow someone for 10, 20 years to realize, oh, this valve that was put in 20 years ago was good or not. And then we're talking about the very small, subtle variations. So at Mayo Clinic, we use the valves that we have adequate data, or we have good, reasonable suspicion that they will last as promised. And there are new technologies that companies try to investigate, which is great, and they try to come up with data. But some of those claims, you have to read the fine prints and make sure that this is not just a promise and it's actually been studied. So that's one of the things I want to caution your viewers to be aware of.
Yeah, very excellent advice. Look for the data, ask the appropriate questions about the durability and the long-term documented success of a particular valve. And we're going to get close here to winding down. I think, Dr. Eleid, you already addressed bicuspid aortic valves and TAVR, so we're going to move past that one. And then we're going to kind of get to a question here that I wanted to ask the two of you, because at the Mayo Clinic, you see so many innovations. You see so many developments happening, from an idea to something you can touch to something you can implant. And I just have a question, we will not hold you to any of this, but in that crystal ball that's in front of you up on the screen, if you were to look 10 years into the future, what and how do you think heart valve replacement procedures will transform going out to 2031?
Mackram, to start now.
Sure. Yeah, I'd be happy to. No, I think that's. I think one thing we're seeing now is that there's really been an explosion of excitement with the transcatheter valve technologies, and this is allowing for treating patients that previously many of whom couldn't be treated. So one of the things is we are able to treat more valve disease in the next 10 years, and that's good because our population is aging, and we know valve disease comes with age as well. So with the aging population, we need to have less invasive treatments. But I think it's going to become more successful. We're going to get better at selecting for transcatheter replacement versus repair. We're going to learn more and more about the best candidates for which procedures. But I think some of the highly successful things like surgical mitral valve repair that Dr. Arghami showed you will continue to be a great option for patients. But do you see that changing at all, Dr. Arghami, your robotic techniques?
I think they're just going to improve as well. I think, as we've seen in the last 10 years, we have gone from an incision this big to now literally tiny pencil-sized incisions, and it just continues to get better and better. The technology continues to improve. We're right now cannulating even without cutting in the groin, which was another incision in the body that we have eliminated. And in terms of surgical valves, as I alluded to earlier on that first question, that there are technologies that can grow your own valve, if you want to say, and the more durable, the more or less reactive the valves are. And we're going to learn more which valves are durable, which techniques that reduce the calcifications of the valve are more useful. And the future is just going to be less invasive, less bothersome to the patient's lifestyle, and more durable.
Fantastic. And I know we just talked a lot about the future, and I just want to bring everybody back to the present. And in the present, I want to be very thankful to you, Dr. Arghami and Dr. Eleid, for taking time to put together this presentation to answer the patient questions. On behalf of our community, the folks that you've already treated and the folks that you'll treat in the future, we can't thank you and the team at Mayo Clinic enough. So thank you for being with us today.
It's been a pleasure.
Yeah, and to all the folks, the wonderful members of the community, please don't exit just yet. I want to take a moment to thank you for being part of this session today and learning all about the advances in heart valve replacements. It's always great to have these community events so that in real time, we can learn together, get educated, and feel empowered. And on that note, I want to thank you as we wrap up this wonderful webinar with a survey that is going to appear on your screen in just about 3 seconds. And so I'll say again, thanks, Dr. Arghami, thanks, Dr. Eleid, and thanks to all the people who attended this webinar. Thank you so much. Hi, everybody, it's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.